Okay, let's unpack this. Did you know that thyroid cancer is actually the most common cancer starting in our endocrine system?
Yeah, it's surprisingly common in that context.
It sounds serious, and well, for some people, it absolutely is. But what the notes we're diving into today really highlight is just how dramatically its behavior can vary.
hmm
We're talking everything from types that are highly curable to others that are incredibly aggressive, fast-moving. It's really not just one single disease.
That variability is, I think, the core insight here.
Yeah.
Understanding thyroid carcinoma means understanding this spectrum, these different faces it can present. It's crucial.
Exactly. And that's our mission in this deep dive. We're working from a detailed set of notes on thyroid carcinoma, and we want to guide you through them,
Yeah, pull out the key bits.
pulling out the most important nuggets, the surprising facts, and those crucial distinctions that help make sense of this complex area without burying you in overload. Let's jump in.
Sounds good. Where should we start?
So, to start, the basics. What exactly is thyroid carcinoma?
Okay. At its most fundamental level, it's a malignant tumor, a cancer, that begins in the cells of the thyroid gland.
Right.
And these cancer cells can originate from either the follicular cells, those are the main ones, or the parafollicular C cells, and which cell it starts in. Turns out to be incredibly important for, well, pretty much everything that follows prognosis, treatment, everything.
And who tends to get this? The notes had some interesting numbers on epidemiology.
They did. One kind of surprising finding is just how much the incidence is increasing globally.
Really? Why is that?
Well, a big reason seems to be better detection. Things like ultrasound-guided biopsies are finding smaller tumors we might have missed before.
Ah, okay. Makes sense. Better tools, more diagnoses.
Exactly. There's also a really significant gender disparity. It's about 3 times more common in females.
3 times.
Yeah.
Wow, that's a substantial difference. Why females?
Well, the notes touch on a possible role for female sex hormones, but it's complex. And age plays a big role too, but it varies quite a bit depending on the specific type of thyroid cancer.
How so?
So papillary, the most common type, usually shows up between 20 and 50. Follicular tends to be a bit later, say 40 to 60.
Okay.
Medullary can be sporadic in adults, but there are also familial forms that can appear in younger patients. And then you have anaplastic, which we typically see in people over 60.
So even the who changes depending on the type. Fascinating. Speaking of why it might develop, what are the main risk factors the notes mentioned?
The biggest one, the one that really stands out, is radiation exposure, especially if it happened during childhood, like therapeutic head and neck irradiation for other conditions or exposure from nuclear fallout.
That makes sense. The thyroid is known to be pretty sensitive to radiation.
Right. And beyond radiation, there's a strong genetic component for certain types.
Like which ones?
The notes specifically mention syndromes like multiple endocrine neoplasia, MNN type 2A or 2B. Those are strongly linked to medullary carcinoma.
Ah, medullary again.
Often driven by a specific mutation, actually, in the RET proto-oncogene. Other syndromes like familial adenomatous polyposis, FAP, or Cowden syndrome also pop up as risk factors for certain thyroid cancers.
Okay, so genetics ties into specific types. Anything else?
Iodine deficiency is linked to an increased risk of follicular carcinoma.
Right.
There's also, as I mentioned, speculation about female sex hormones contributing to the higher incidence in women. And of course, just having a family history of thyroid cancer increases your risk.
Okay, that gives us a picture of the basics, the who, and some of the why. But as you said earlier, the type is everything.
Absolutely critical.
Here's where the real complexity and maybe the key insights kick in. Let's break down these different faces of thyroid cancer.
Definitely. Understanding the specific type someone has is arguably the most critical piece of information. It dictates prognosis, it guides treatment, it's fundamental.
Let's start with the most common ones then, the differentiated thyroid cancers.
Oh.
Because they generally have the best reputation, right?
Yeah. Generally, yes, that's right. These arise from the follicular cells, and they're typically slow-growing with a good prognosis overall.
Okay.
Papillary carcinoma is the big one here, making up about 80% of all cases. 80%.
80. Wow.
And its prognosis is excellent. We're talking over 90% 10-year survival.
That's really good news for most people diagnosed.
It is. A key feature you'd see under the microscope is the presence of psammoma bodies. These are tiny, very distinctive calcium clumps, kind of a hallmark.
Okay, psammoma body's a microscopic clue for papillary. What about follicular? That's the other differentiated one.
Right. Follicular is less common, maybe around 10%. It generally has a slightly less favorable prognosis than papillary.
Still good, but not quite as good.
Exactly. And pathologically, a key feature is vascular invasion. That means the cancer cells are seen growing into blood vessels.
Which sounds like it could make it easier for them to spread.
That's the concern, yes.
Yeah.
It potentially increases the risk of metastasis. There's also a subtype called Hürthle cell carcinoma, which the notes describe as being a bit more aggressive than typical follicular,
Okay.
characterized by a specific cell appearance called oncocytic cells, lots of mitochondria.
So even within this better prognosis group, there are these important distinctions in behavior and what they look like microscopically.
Precisely. Nuances matter.
Okay, what about medullary carcinoma? You mentioned it comes from different cells.
That's right. Medullary makes up about 5%, and it arises from the parafollicular C cells, not the follicular cells.
These cells. Got
Its
it.
prognosis is more moderate, and it heavily depends on the stage when it's found. Now, a very important detail about medullary is that these C cells secrete calcitonin.
The hormone.
Yes. And remember that genetic link we talked about, the RET proto-oncogene and MEN2 syndromes?
Yeah.
That connection is strongest with medullary carcinoma, often runs in families.
That calcitonin secretion sounds like it could lead to some unusual symptoms, maybe?
Yeah.
That we wouldn't expect just from a neck lump.
It certainly can. We'll touch on that.
And then there's the one with the really grim outlook, anaplastic.
Anaplastic, yes. It's rare, thankfully, only 1–2% of cases. But it's a truly aggressive, dedifferentiated form of thyroid cancer. It's like the cells have lost all their normal features.
And the prognosis reflects that.
Unfortunately, yes, very poor. The median survival is often measured in months, maybe around 6 months, and the 5-year survival rate is less than 10%.
Wait, hang on. So you're telling me the difference in 5-year survival between papillary, the most common, and anaplastic is over 95% versus less than 10%?
That's correct. The contrast is absolutely staggering.
Wow. That alone just underscores how vital it is to know the specific type. It's almost like they're entirely different diseases that just happen to start in the same gland.
It absolutely does. It really highlights the spectrum. And yes, there are other very rare types like lymphoma occurring in the thyroid or cancer spreading to the thyroid from elsewhere, but the vast majority of thyroid cancers and that dramatic range of behavior are covered by the differentiated medullary and anaplastic types.
Okay. Let's talk about how these differences manifest clinically then. What does thyroid cancer typically look like when someone first sees a doctor?
Often, and perhaps surprisingly, the most common presentation is simply a painless thyroid nodule or a lump in the neck.
Painless?
Often, yes. It might be found incidentally, during a routine physical exam or maybe imaging done for a completely different reason.
So often quite subtle initially, not causing major problems right away.
Exactly. But as the tumor grows, it can start to cause symptoms, usually by pressing on nearby structures in the neck.
Like what?
Well, it can lead to hoarseness if it affects the recurrent laryngeal nerve, which controls the voice box.
Okay.
Or difficulty swallowing, dysphagia if it compresses the esophagus, which runs right behind the thyroid.
Yep.
Swollen lymph nodes in the neck, cervical lymphadenopathy are also pretty common, particularly with papillary carcinoma, which likes to spread to lymph nodes early.
Okay, so pressure symptoms are a possibility. What about that calcitonin secretion you mentioned for medullary? Does that cause unique symptoms?
Ah, yes, that's a key differentiator for medullary carcinoma. Because those C cells are pumping out calcitonin, sometimes other hormones too, some patients can experience systemic symptoms like diarrhea and flushing.
Diarrhea and flushing from a thyroid cancer.
Yes, specifically medullary, it's caused by the hormones it secretes.
That's fascinating symptoms you really wouldn't immediately connect to a mass in your neck. Very specific clue. And for the aggressive anaplastic type, how does that usually present?
Given its incredibly rapid growth, anaplastic carcinoma typically presents as a quickly enlarging, hard, fixed mass in the neck. It feels different.
Fixed, meaning it doesn't move easily.
Exactly. It suggests it's invading nearby tissues, and its aggression often leads to symptoms of airway compromise pretty quickly. Things like noisy breathing, which is called stridor, or even sometimes complete airway obstruction. It can be a medical emergency.
That really paints a picture of how the underlying biology, the pathology, drives the symptoms you see. Okay, so if a suspicious nodule is found or someone has these symptoms, how do doctors figure out exactly what type it is and how far it spread? What's the workup?
Right. The diagnostic process is quite systematic. It involves a combination of lab tests, imaging, and crucially, getting a tissue sample.
Okay, let's break that down. Labs first.
For lab tests, it's interesting. Standard thyroid function tests, checking TSH, T3, T4 levels are usually normal.
Really? Even with a cancer?
Yeah, the nodule itself, even if cancerous, often isn't producing hormones in a way that disrupts the whole gland's function. It's often cold, functionally.
Huh. That's another counterintuitive point. Normal hormone levels definitely don't rule out cancer in a nodule.
Correct. A very important point. However, those specific markers we discussed, calcitonin and another one called CEA, those are specifically tested for if medullary carcinoma is suspected, and they're used to monitor it. And thyroglobulin is another important tumor marker, but it's mainly useful for follow-up after the thyroid has been removed in patients with differentiated thyroid cancer.
After surgery.
Got it.
Okay, so labs help narrow things down or monitor later. What about imaging?
Imaging is key. Ultrasound is usually the crucial first step for looking at a nodule.
What does ultrasound show?
It lets doctors look closely at the nodule's features. There are certain signs on ultrasound that raise suspicion for cancer, like if the nodule looks dark or hypoechoic. If it contains tiny bright spots called microcalcifications, if it has irregular edges, or if it shows increased blood flow within it.
And doctors use these features to assess risk.
Exactly. There's even a scoring system called TIRAD, Thyroid Imaging Reporting and Data System, that helps standardize the report and estimate the risk of malignancy based on these ultrasound characteristics.
Okay, so ultrasound tells you if it looks suspicious enough to investigate further, and that's where getting a tissue sample comes in.
Precisely. Fine needle aspiration, or FNA, is considered the gold standard for diagnosing thyroid nodules.
How does that work?
A very thin needle is guided, usually with ultrasound, into the nodule to collect cells. Those cells are then examined under a microscope by a pathologist.
And they can tell the type from that.
They often can, or at least narrow it down significantly. The results are classified using a standardized system called the Bethesda system for reporting thyroid cytopathology, which helps guide management.
Got it. Bethesda system for FNA results. FNA is key for the diagnosis itself. What about scans to see if it has spread?
Right. If there's concern the tumor has invaded nearby structures in the neck, or if there's suspicion of spread to distant sites like the lungs or bones, then CT or MRI scans might be used. And there's one more imaging test, a radioactive iodine scan using I-123 or I-131. This is used sometimes for staging and also for detecting any remaining thyroid tissue or spread after surgery. But this is only applicable for the differentiated types, papillary and follicular.
And that's because only those differentiated follicular cells have the cellular machinery to actually take up iodine, right? The other types don't.
Exactly right. Medullary carcinoma arising from C cells and anaplastic carcinoma being dedifferentiated don't typically concentrate iodine. So an iodine scan wouldn't show them, it would be negative.
That connection makes perfect sense now. It all links back to the cell of origin. You also mentioned genetics earlier playing a role in risk. Is genetic testing part of the standard workup for diagnosis too?
It's becoming increasingly important, yes, especially in certain situations. Identifying specific gene mutations can help refine the diagnosis, predict prognosis, and sometimes even guide treatment choices.
Like the RET gene for medullary.
Exactly. Testing for the RET proto-oncogene mutation is pretty standard if medullary carcinoma is suspected or confirmed, especially to check for those familial MN syndromes.
Okay.
And another important one is the BRAF V600E mutation. This is often found on papillary carcinoma and is associated with a somewhat higher risk of recurrence or more aggressive behavior. Knowing about it can influence treatment decisions.
So it's not just looking at how the cells appear under the microscope anymore, but actually looking inside their genetic code for clues. That's fascinating stuff.
It really is. Molecular pathology is playing a bigger and bigger role.
Okay, let's talk about what happens once a diagnosis is made. What's the treatment approach? How is it tackled?
Treatment is very much tailored. It depends heavily on the specific type, the size of the tumor, the stage, meaning how far it has spread, and also patient factors like age and overall health. But that said, surgery is almost always the main initial treatment.
Removing the thyroid gland.
Yes. A total thyroidectomy, which is removing the entire gland, is typically preferred for larger tumors, say, over 1 centimeter, or if there are multiple nodules, or if it has high-risk features on pathology or known spread.
Is the whole thyroid always removed?
Not always.
Yeah.
For very small, low-risk papillary cancers, sometimes just removing half the thyroid, the lobe containing the cancer, is an option. That's called a lobectomy.
Okay.
And if the cancer has clearly spread to lymph nodes in the neck, those are removed at the same time during surgery in an operation called a lymph node dissection.
Okay, so surgery is central, aiming to get the primary tumor out. What else is typically involved? You mentioned radioactive iodine earlier.
Right. Radioactive iodine therapy, or RAI, using iodine-131 is often used after surgery. But again, remember, only for differentiated thyroid cancer papillary and follicular types.
And because they take up iodine. Got it. And who gets RAI after surgery? Is it everyone with those types?
Not necessarily everyone. It's typically recommended for higher risk cases. For example, if the initial tumor was large, maybe over 4 centimeters, or if there was definite spread to lymph nodes, or if the tumor had grown outside the thyroid capsule into surrounding tissues, what's called extrathyroidal extension.
So it's for cleaning up potential microscopic disease left behind.
Exactly. To ablate or destroy any remaining thyroid cells, normal or cancerous, and to treat any microscopic spread. And just to reiterate, it's contraindicated, not used, for anaplastic or medullary carcinoma because their cells don't absorb the iodine.
Understood. Differentiated types only for RAI. Now, if the whole thyroid is removed, patients need hormone replacement, right?
Absolutely. Patients who've had a total thyroidectomy will need to take levothyroxine, which is synthetic thyroid hormone, for life to replace what their gland used to make.
Just standard replacement.
Well, yes, but interestingly, it's often given at a dose that's slightly higher than just pure replacement. The goal is to suppress the level of thyroid-stimulating hormone, TSH, from the pituitary gland.
Why suppress TSH?
Because TSH can actually act as a growth factor for thyroid tissue, including any potential remaining differentiated thyroid cancer cells. So keeping TSH levels low helps reduce the risk of the cancer coming back or recurring.
So you're replacing the hormone the thyroid made, but also using that replacement strategically to suppress something that could potentially fuel any leftover cancer. That's clever.
It is. It's called TSH suppression therapy.
Okay. What about other types of radiation, like external beam radiation?
External beam radiotherapy, or EBRT, is used less often than surgery or RAI for thyroid cancer overall, but it has important roles. It's a key part of treatment for the very aggressive anaplastic carcinoma.
Right, because surgery and RAI don't work as well there.
Correct. It's also used for tumors that couldn't be completely removed by surgery, or for treating metastases, especially bone metastases, that don't take up radioactive iodine.
Okay. And for advanced cases, maybe where the cancer has spread widely or come back and isn't responding to RAI anymore, what options are left then?
This is where targeted therapies have really made a difference in recent years, especially for certain types. These are drugs designed to specifically attack molecular pathways that the cancer cells rely on to grow and survive.
Can you give some examples?
Sure. The notes list several. For differentiated thyroid cancers that have become refractory, meaning they no longer respond to radioactive iodine, drugs like sorafenib and lenvatinib can be used.
Okay.
For metastatic medullary carcinoma, specific tyrosine kinase inhibitors like vandetanib and cabozantinib are options.
Targeting pathways important in medullary.
Exactly. And connecting back to that genetic testing we discussed, for anaplastic carcinoma that has the BRAF V600E mutation, the combination of dabrafenib plus trametinib, which target that specific pathway, can be used.
Wow, so the specific genetic tests we talked about earlier can directly determine which of these targeted drugs might actually work for a patient. That really shows how personalized treatment is becoming.
It absolutely does. It's moving away from one-size-fits-all towards treatments tailored to the molecular profile of the tumor. And chemotherapy, traditional chemo, also has a limited role, mainly used in anaplastic carcinoma, sometimes alongside radiation, with drugs like paclitaxel or doxorubicin.
Okay, so summing up treatment. Surgery is central, often followed by RAI for differentiated types, TSH suppression to prevent recurrence, and then external radiation or these newer targeted therapies for more challenging cases or specific subtypes like anaplastic or advanced medullary. It sounds like a comprehensive but very type-specific approach.
That's a great summary. Highly individualized based on type and risk.
Looking ahead then, what's the typical prognosis? We touched on the survival rates, but maybe recap that stark contrast. And how are patients followed long-term?
Right. The prognosis, again, depends massively on the subtype, as we've really emphasized throughout. Just to reiterate those dramatic numbers because they're so important, papillary has excellent outcomes, generally over 95% 5-year survival. Follicular is also very good, maybe 85–90% 5-year survival. Medullary is more moderate, variable, but maybe 75–85% 5-year survival overall, depending heavily on stage.
Okay.
And anaplastic, tragically, remains very poor, with less than 10% 5-year survival.
Those numbers really are the most striking takeaway about how incredibly different these diseases lumped under thyroid cancer truly are.
They really are. And the notes also list some key poor prognostic factors that can worsen the outlook, even within a specific subtype.
Like what?
These include being older, usually over 55 at diagnosis, being male.
Oh, interesting, despite it being more common in females.
Yes, males tend to have slightly worse outcomes when they do get it. Also, having a large tumor size, the presence of distant metastases at diagnosis, and if the tumor has grown outside the thyroid gland capsule into nearby tissues, that extrathyroidal extension we mentioned.
Several factors beyond just the basic type can influence the individual outcome. And after initial treatment is done, how do doctors keep an eye on things? What does follow-up involve?
Follow-up is absolutely essential, lifelong in many cases, and predictably, it's tailored to the specific type of cancer the person had.
Oh, so.
For differentiated thyroid cancer, papillary and follicular, monitoring involves regularly checking that thyroglobulin level in the blood. Remember, it's the marker made by thyroid cells.
Uh-huh. If it starts to rise, that's a concern.
Exactly. It could signal recurrence. That's combined with periodic neck ultrasounds to visually check for any suspicious lumps or lymph nodes.
Okay, thyroglobulin and ultrasound for differentiated. And for medullary.
For medullary carcinoma, follow-up relies on monitoring those other markers. Calcitonin and CEA levels in the blood. Again, rising levels would be concerning.
Makes sense, tracking the specific markers for that cell type.
Precisely. And for differentiated types, if a recurrence is suspected based on rising thyroglobulin or imaging, and it seems potentially iodine-avid, a whole-body radioactive iodine scan might be used again to locate it.
It really all ties back beautifully, or perhaps complexly, to the specific characteristics of each type. The cell of origin, the markers it produces, its ability to take up iodine.
Absolutely. It's all interconnected.
So what does this deep dive into the notes all mean? What's the big picture here?
I think ultimately it means that thyroid carcinoma is emphatically not a single disease. It's a whole spectrum of conditions with vastly different behaviors, genetic drivers, and outcomes.
Right.
And while the majority of types, particularly the differentiated ones like papillary and follicular, have excellent prognosis with timely diagnosis and appropriate treatment, the aggressive forms, especially anaplastic carcinoma, remain a significant clinical challenge despite recent advances.
And the notes really highlighted how things like genetic testing and these increasingly precise targeted therapies are really vital and evolving tools, particularly in managing those more difficult or advanced cases.
Exactly. It's a field where understanding the specific molecular nuts and bolts of the cancer is increasingly shaping how we diagnose, predict outcomes, and, critically, how we treat it. Personalized medicine in action.
That makes perfect sense. Thinking about how much the prognosis and the treatment depends so heavily on the specific type of thyroid cancer based on things like its cell of origin, its microscopic appearance, even down to specific genetic mutations.
Yeah.
This deep dive really raises an important question, something for you, the listener, to consider. How does achieving this level of precision in classifying a disease like thyroid cancer transform how we should approach diagnosis and management for other cancers, or maybe even other complex chronic health conditions? Where else could this kind of detailed subtyping make a critical difference?